This is an ECG of a 68-year-old man with a documented history of an idiopathic cardiomyopathy and normal coronary arteries. Let's look at his ECG. We can start by examining the long rhythm strips that are at the bottom of the tracing. Looking at lead 2, we can see that there are P waves before every QRS complex. The P waves are positive in lead 1 and positive in lead AVF, thus originating from the sinus node. The rate is about 95 beats per minute. In lead V1, the negative component of the P wave is deep and wide, in keeping with left atrial enlargement. In addition, in lead 2, the P wave is tall, in keeping with right atrial enlargement. Thus, this patient has biatrial enlargement. The PR interval is normal. The QRS axis is positive in lead 1. In lead AVF, there are subtle changes in the RS ratio between this beat and the next, likely related to respiration. On average, however, the R wave and S wave are about equal, suggesting that the axis is perpendicular to AVF. The axis is thus 0 degrees, which is normal. Because the QRS complex is narrow and sharp, there is no evidence of any intraventricular conduction delay. Let's examine for ventricular hypertrophy. The R waves are quite tall in lead V5 and V6. The sum of the S wave in lead V1 and the R wave in lead V6 is well over 35 millimeters, which supports the diagnosis of left ventricular hypertrophy. Here, there are no evidence of any abnormal Q waves, suggesting no evidence of infarction. There are negative T waves in lead 1, AVL, V5, and V6, although the STT pattern is not typical for the strain pattern related to left ventricular hypertrophy. This patient had previous coronary angiography demonstrating normal coronary arteries, suggesting that the inverted T waves are likely a variation of the strain pattern that can be seen with left ventricular hypertrophy. Overall, this ECG shows normal sinus rhythm at 95 beats per minute with biatrial enlargement and left ventricular hypertrophy with repolarization abnormality.